Conceiving a Healthy Recovery, exploring the connection between fertility, motherhood, and eating disorders. My name is Lydia Rhino, the Program Director at the Eating Disorder Foundation, and I am excited to be here with everyone tonight. And for those of you watching on YouTube, also welcome, excited to share the space with you. Today's workshop is brought to you in collaboration with the Eating Disorder Foundation and Kate Daigle. I would like to share a moment about the Eating Disorder Foundation. We're a nonprofit that was founded in 2003 with a mission to be an effective resource in the prevention and elimination of eating disorders through free and accessible education, support, and advocacy. We are a Denver-based organization that is now serving individuals and families both nationally and internationally. I want to thank anyone who's made a donation upon registration. We are able to provide free services because of the generosity of our community. I'll add the donation link in the chat if you wish to contribute. All right, if anyone has questions for the presenter, I invite you to go ahead and use the chat feature to communicate with me directly throughout the workshop. The chat is kept confidential and will come to me directly, and we'll save time for Q&A after the presentation, and I will deliver those questions to our presenter. We'll not be sharing the PowerPoint. However, we are recording tonight, and we'll send the recording as soon as possible. I would like to now introduce our speaker. I'm going to go ahead and read Kate's bio, and then we'll get started with the presentation. Kate Daigle is an LPC and certified eating disorder specialist with a private practice in Denver since 2010. She is the author of the Clinical Guide to Fertility, Motherhood, and Eating Disorders, and does presentations and workshops all around the country. Kate is a mother and an eating disorder survivor, and through her own journey with fertility and recovery, is passionate about exploring the connection between these conditions and helping clients feel empowered and free. Kate has been volunteering at EDF since 2008 and is very excited to present once again to the EDF community and beyond. Information about her book and practice can be found, and I will plug the website in the chat as well. So we will go ahead and get started now. Kate, I'm going to turn it over to you, and I'll plug these links into our chat for folks, but we'll also put those in the little notes on the presentation as well. But Kate, take it away.
All right. Thanks, EDF, for having me again. I'm very excited and passionate about this topic of fertility, motherhood, and eating disorders and the connection between all of those. And I'll go into more about why in just a moment. So this is a presentation I've done, as Lydia said, around the country, and it's gotten a lot of great feedback and interest. So I'm excited to share it again and get some more questions and feedback from you all. So why this topic? As Lydia said, I had my own personal experience recovering from an eating disorder. When I was in my teens and early 20s, I experienced anorexia and bulimia for about 10 years before I finally was able to experience a full recovery with treatment and therapy, and went on years and years later to open my practice and was focused on eating disorders ever since the beginning of my practice. When I got married to my husband and we wanted to try to have a family. I experienced a couple of losses, miscarriages, before I was able to have my daughter, who's a healthy 8-year-old now. But through those losses and the grief and the devastation, I experienced also some guilt and some shame around, did I hurt my body through my experience with my eating disorders? And I didn't know. My doctors said, no, this was kind of just what had happened. But once I had my daughter, I was very curious about the intersection of eating disorder recovery and fertility issues. And I tried to go in and get some knowledge about it and do some research, and there really wasn't a lot on the topic. So what I did was kind of do some of my own research. I submitted a proposal to the Eating Recovery Center conference that year in 2017, and on this topic was accepted. And so this kind of began my journey on my own professional experience with mothers and parents who've experienced infertility and or eating disorders, and how that relates to the parenthood and postpartum experience. So since that time, I've been focusing a lot of my professional career on that, and wrote a book on this topic as well, published in 2019, which I will give some more info at the end. So that's why I've been doing this, and I did a lot of research, and I'm happy to share it with you. Some of this you already know if you're part of this community, but I need to go over some definitions and some data. So infertility defined is being unable to conceive after 1 year of regular unprotected sex. It can involve recurrent pregnancy loss, such as 2 or more spontaneous miscarriages, which was my experience. Eating disorders review. They have the second highest mortality rate of all mental illnesses behind substance use disorder. Full recovery is possible with effective treatment. I work with lots of people in that category, and I am one of them as well. But these are a very destructive combination of mental, emotional, and physical health issues. So anorexia, bulimia, binge eating disorder, orthorexia and pregorexia, and other specified eating disorder are kind of the catch-all. These are the categories of eating disorders. I would say most eating disorders are on a spectrum. They don't fit into one specific category, but can oscillate between several of these diagnoses. Orthorexia and pregorexia are not in the DSM. I'll go over those a little bit more. They are pretty common as well. So when I was doing my research about eating disorders and fertility treatment, I saw that almost twice as many women with a current eating disorder seek out fertility treatment than women who have not ever had an eating disorder, which was not surprising, but it was interesting to see those statistics about it's more common for women with an eating disorder to seek out some kind of fertility treatment. As many as up to 80% of women will go on to conceive after being successfully treated for an eating disorder. And women in full recovery have the same chance of getting pregnant as women who have never had an eating disorder, unless there are other non-eating disorder related fertility struggles in the mix. So I like to put this slide out there as like a positive, hopeful case of such as me and many of the women that I know in the community have had babies, one or more, after having successfully recovered from an eating disorder. So in my research, I focused on 2 populations. One was women in sustained ED recovery, 3 or plus years, who experience fertility issues, and women with an active eating disorder or disordered eating who get pregnant intentionally or unintentionally. And then the experience of shame with both of these populations. As you might understand or imagine, there's shame with eating disorders, period, and then shame if infertility or your body not working as you had hoped comes into that experience that you're trying to have. So I looked at the experience of conception, pregnancy, and postpartum/motherhood with both of those populations I just described. So with conception, medical complications with having an eating disorder are amenorrhea, which is an absence of menses for 3 or more months. Of women with an anorexia-like illness, up to 89% report disruption of their menses for at least 3 months. And after significant chronic weight loss, the reproductive organs regress back to pre-pubertal state, which means going back to a state, the body is not able to sustain reproductivity. So they go back to a state of almost adolescence and not able to even get pregnant because there isn't enough nutrients and body fat to sustain a pregnancy at that point. The brain perceives famine and goes into a protective state. Fertility hormone production is disrupted. And I interviewed Dr. Gadiani about this topic, and she says even with these conditions, eggs can still happen. So women can still be ovulating even if these conditions of anorexia are occurring. Additional medical concerns of eating disorders are poor nutrition, dehydration, hormone imbalance, and as I said just now, not enough body fat to sustain a pregnancy, to either conception, pregnancy, or delivery. Cardiac irregularities, poor bone density, which is a significant um, factor in eating disorders as well. And then we look at the emotional challenges. This I certainly dealt with myself. Grief, recurring. Will it be this month? No. Okay. Will it be next month? No. Okay. Anxiety, waiting impatience, loss of control, the experience of shame, guilt, fear, projection of emotion on others, especially a partner, isolation, financial issues. All of these occur with infertility issues, but also just with eating disorders in general. So PCOS, which I am sure you're familiar with, it's an endocrine disorder affecting up to 18% of women who are of reproductive age. But many of these women are not diagnosed, or they're diagnosed later in life once they have started to try to have a family. So there's a lot of emotional distress that can result from PCOS that can trigger ED symptoms, especially if doctors recommend weight loss, which we'll get to that in a little bit, but many doctors recommend weight loss as a form of managing PCOS, but that is not always healthy for anyone, especially somebody who's um, had an eating disorder or may develop one. Um, so compared to women without PCOS, women with PCOS have over three times likely to have an ED diagnosis. So up to 22% of women with PCOS meet criteria for an ED diagnosis, and up to 58% of women with PCOS can have ED symptoms. There's still a lot of research that needs to be done on all of these topics and populations, but what I found was a link between PCOS and binge eating may include metabolic, hormonal, and psychological factors. So, elevated androgens may trigger binge purge behavior in PCOS. Hormonal altered insulin levels may lead to disordered dieting cycles, and psychological PCOS is associated with high levels of body dysphagia, uh, increased mood disorders, and more disordered eating. So insulin resistance occurs in women with all body types who have PCOS, not necessarily weight related. So this is a huge thing in the community of doctors, assuming that a woman at a certain weight um, might have PCOS, or if you have PCOS, you might be at a certain weight, and that's not necessarily true. So one of the ways that is helpful to intervene with PCOS is to suggest health at every size, or healthy, balanced ways of managing stress, anxiety, movement that are not just focused on weight. And what I found was a call to action of a full screening of an eating disorder needs to be done before suggesting any kind of weight loss for PCOS. So in that conception with eating disorders type of population, a significant study that I found of pregnant women with anorexia, 40% reported unintentional pregnancy. And this was just one study. But what I learned through this research is that there's many false beliefs, like Dr. G had said, eggs happen. There's many false beliefs that the ability to get pregnant when you have an eating disorder feels like not possible, but that's not actually true. So that might contribute to lack of contraceptive use. And so doctors, again, need to assess and educate patients about that. In that same study, negative attitudes toward pregnancy were more common among women with eating disorders than in the general population, probably because their bodies were going to be changing. And if they did not intend to have this pregnancy, that would be very disruptive for them. Um, Patients with anorexia more frequently viewed motherhood as a personal sacrifice and cited fear of losing their anorexic identity. And again, these were patients who did not intentionally want this pregnancy, so they were not ready to let go and let go of the ED personality identity and embrace more of the motherhood nurturing identity. Other findings suggest that women with anorexia tend to create a new connection with their bodies while pregnant, uh, with replacing that with a healthy relationship with their bodies. So they're wanting to nurture their bodies to nurture this fetus and have a healthy baby, healthy pregnancy. And so the identity shift of the old anorexic self to the new pregnant self is a positive and may aid in remission of anorexic behaviors, at least while pregnant. So if you have a therapist or are a therapist and have a client who is pregnant, then helping them kind of feed into this identity of healthy body, healthy mom, body's changing because it's growing a baby is a really good thing to focus on. Again, in this study, rates of intentional pregnancy were 58% in women with anorexia and 72% in the general population. So that just kind of goes over again that it's not as high of a rate of intentional pregnancy in women with eating disorders. And the women who were not intentionally pregnant had negative feelings about weight gain, fear of losing control of the eating disorders, changes in identity. Bulimia, one of the studies I looked at with bulimia was about causing birth defects and premature birth due to the nature of the binging and the purging and electrolyte loss and just other factors that can really affect pregnancy. A point of study that needs more research is women with active binge eating disorder had a higher rate of miscarriage than the general population. It said up to 50%. Again, all of this is needing more research and a lot of factors leading into it. The journey to motherhood is often more complex among eating disorder populations than the general population. Many women show up at infertility clinics with undiagnosed and undisclosed eating disorders. You could probably guess why: stigma, fear of losing their ED, shame, etc. Only 1/3 of women who'd had an eating disorder report this to their OB. And I will say, I was one of them. My eating disorder was like over 2 decades ago, but I didn't think that could be a factor in mine. And ultimately it wasn't, but that again spurred my research on this topic. So now we're going to go into during pregnancy and challenges that an eating disorder can present. So proper nutrition. 60 to 70% of eating disorder patients experience remission during pregnancy, but up to 75% will relapse by 18 months postpartum. So it's a good sign that there's remission for many, many, many women during pregnancy, again, because they want to embrace their healthy mama, healthy baby identities. But the challenges of new parenthood, amongst other things, can lead to a relapse for many of those same women. So body image during pregnancy and after, losing, again, the eating disorder identity, challenges of premature births, difficulty nursing and bonding. I also found that there was a higher rate of induced abortions among women with an active eating disorder than of those without. And then pregorexia, which I said is not in the DSM, but it is kind of a sister of anorexia, of women who are pregnant who are restricting to avoid the inevitable weight gain, which is healthy for their baby. However, is in society feeds into this about looking at your body and counting calories and how many pounds you're gaining, and then especially afterwards, postpartum too, of how you get back to your body, pre-baby body, which is a lot of pressure. This is just a study I looked at too that was saying like is there fetal programming, which means if there's certain weights of babies that may be more likely to develop binge eating later in life, or if there were certain sizes of babies based on their feeding early in life that might be more likely to develop anorexia. This is a study that, again, needs more research, but it was just something interesting to look at how maybe feeding in the womb or struggles with that might contribute to later issues with eating. So again, there's a lot of more studies that need to be done. So mood disorders are really important to look at with pregnant women in general. We're going to look at those, not just eating disorders, but and like anxiety, depression, bipolar, other things that can contribute. So one of the studies I found was that in a sample of pregnant women, 1.5 had active eating disorders and 15% had experience in eating disorders some point in their life. So that gives you a sense that up to 16% of women have had an eating disorder at some point in their life. And I think that's pretty accurate to current trends with that research. And of women who had experienced an eating disorder, many were more likely to have current depression and anxiety compared to women who had not had an eating disorder. In the same population, the women who with active eating disorders were more likely to have current anxiety and borderline personality disorder traits compared to women without a current eating disorder. So even those clients who had recovered from an eating disorder may need extra support during their pregnancy and postpartum journey. And if you've had anxiety or depression prior to pregnancy, one is more likely to experience it postpartum as well. So again, just more screening or support could be needed. This was an interesting piece that I found to a new eating disorder. So as you might know, eating disorders do not like to be threatened. And a pregnancy or a baby, as we talked about, a new identity might threaten that eating disorder. So it is fairly common that an eating disorder might shift during pregnancy into a new type of identity. So, for example, if someone had binge purge, like bulimia type of eating disorder, and they recognize how dangerous that is for their baby, that might shift to maybe just binge eating. Or restriction might turn to binge eating, or just kind of along a range of behaviors like that. So there's often a tug of war between the eating disorder and this like healthy mama identity. And so just holding space if you are someone who's had that experience, or a therapist, or it's not often black or white. There's a spectrum of needs and identities that can happen during a pregnancy. As I mentioned earlier, the possibility of remission of an eating disorder is up to 75% postpartum. Not necessarily, but that's why the need to get support and help postpartum is really important. So while one is pregnant, if you're a therapist or if you're in therapy, to do a lot of work on reinforcing this healthy self, this long-term recovery, this person who wants to nurture herself and her child postpartum, it's a good time to really focus on those pieces. I personally have a really hard time with the term miscarriage because it kind of blames the woman, and it's very old term, and it's blaming that she kind of couldn't carry this baby. And in reality, up to 50%, there's a lot of statistics, but in eating disorder population, up to 50% can be resulting in miscarriage. 10 to 30-ish% in the general population. Most of these are genetic issues that are nothing to do with the woman or the man who wanted this pregnancy, but it's something that can lead to more shame in this population. So for me and for many of my clients, it was like, did I do this to my baby? Is that my fault? Um, and again, if it happens, it's most likely something that has nothing to do with the person, but um, pregnancy loss is a better term to talk about, to use with this population. So then the third population I worked with and talked about is postpartum, which is really important in attachment and also recovery physically, but also recovery from the eating disorder and it reemerging or bonding with the child. So there's a lot of physical and emotional recovery. There's a lot of identity issues, changes that happened from pregnant to parent, and a lot of new challenges such as bonding with the child, nursing, um, sleeping, feeding, and all of these partner issues. There's a lot of things that come up once you've had this child. So again, there's an elevated risk of postpartum or depression or anxiety in those with an active or past eating disorders. So it's just something to keep aware of. Um, in another one of the studies I looked at, active symptoms of bulimia were associated. So someone who has active bulimia, where it was associated with over concern and over restrictedness of their infant, especially around food in the first year of life. So somebody who's still working on their own eating disorder can kind of feel more controlling and over attentive to feeding their child. And disordered eating had a negative effect on parenting in general. Attachment is huge for us as human beings, but especially with young children as they're learning to be in the world and attached to their parents, family members. So what I looked at was like, what were the most common experiences of attachment with, uh, so I looked at with kids. So dismissive avoidant attachment was the most common type among children and teens who develop eating disorders. So, what that really related to for me is someone who is struggling with an eating disorder, like a parent, might not be as available to take care of their child's needs, not intentionally, but just because of what they were dealing with. And that can lead to a child fearing intimacy, kind of pulling away, not knowing if a reliable caretaker can take care of them. And so that can develop later in life to some dismissive avoidant tendencies. However, the most common attachment style of, of mothers was anxious, preoccupied with their children if they had an active eating disorders. So the mother might be desperate to bond with their child because they're unsure of their own identity due to an eating disorder. Um, they're they want to rescue and make sure that they're really attached to their child because they're struggling with their own identity. So that's not necessarily a bad thing to be attached to their child, but it's looking at how that's also affecting the child's identity development and the recovery and healing of the parent. And there's a lot more to all of this attachment stuff, but it's super interesting. Additional postpartum factors, body image, which is like the body changing significantly during pregnancy, but then also afterwards. Nursing. So, nursing can become more complicated if somebody has an active eating disorder. It can affect their milk supply and ability to latch and bond with their child. And body image dissatisfaction has been associated with reduced breastfeeding intention and duration too. Again, there's other ways to feed the child. So it's not just about nursing, but if a mom is struggling to nurse for various reasons, there's other resources available to her. Again, just adjusting to a new family system, postpartum issues, the possibility of relapse, and then more research is needed. Anorexia is the most studied eating disorder in general, but also the most studied in this population, post pregnancy and postpartum. So there's a lot more research that is needed. So this calls for collaboration between therapists, nutritionists, the medical team, psychiatrists, to make sure these moms and their partners are in the best hands possible to have a healthy pregnancy and a healthy delivery and a healthy postpartum. And what needs to happen most with especially women who are in active or recovery from eating disorders is a health at every size approach, um, which I think you might be aware of, but I'll go over more of that. What I found were barriers to care in the medical community where, as I mentioned a little bit earlier, up to 1/3 of patients do not disclose if they've had an eating disorder. So that's again shame, fear, guilt, but also up to, in a study I looked at, up to 2/3 of these patients were not assessed for eating disorders. So they didn't want to disclose, they were not assessed, it just wasn't talked about. So um, medical MDs often just don't feel confident in how to talk to, how to assess uh, these patients because they had, on average, maybe even less, one course on eating disorders in medical school. So again, Dr. Gaudiani said, "I'm continually astounded by the damaging power of physician internalized size stigma." So there's a lot of assuming that women in a larger body or a smaller body will have certain things happening to them medically that are not necessarily true and just are judged based on that. So one of the studies I looked at as by patients, when they went to the doctor, and again, they didn't feel comfortable disclosing, there was stigma about either their weight or disclosing an eating disorder. There's lack of opportunity, meaning there wasn't enough time or space to bring this up. Many of the patients preferred self-management. They didn't want to share it with their doctor, or they were like, we're good. I got it on my own. I'm fine. They're actively in their eating disorder. So they didn't really want to share it, or it wasn't perceived by the medical professional, or even that it was an eating disorder. Maybe that it was just kind of normalized. And then another piece to this is the factors that a physician might see in terms of being able to assess a patient. So system constraints. So like I said, minimal to no training in eating disorders. The physician might see the recognition of role. They're not supposed to be the one to advise or support, or they're not supposed to intervene. They're more to advise or support. But if they don't feel like they have the training, then they don't really know what that even actually is. Personal attitudes. So there's still a lot of bias in the medical community towards eating disorders and weight in general. So whether they're aware of it or not, there might be values, beliefs, bias that will affect how they would assess an eating disorder. And then there's just the stigma. Nobody wants to bring it up. Nobody wants to talk about it. It's uncomfortable. So more than likely, it's just not brought up. But the health at every size approach is the most effective, ethical, and comprehensive way to treat eating disorder and fertility issues. So health at every size supports the following principles: respect, critical awareness, compassionate self-care. It supports people of all sizes in addressing health directly by adopting healthy behaviors. It's an inclusive movement recognizing that our social characteristics, such as our size, race, national origin, sexuality, gender, disability status, and other attributes, are assets, and acknowledges and challenges the structural and systemic forces that impinge on living well. So that's a lot, but it's basically like we're looking at the whole person and not just how they look or weigh or are perceived, but we're looking at the whole person. So what I wanted to share, I'm just looking at the time really quick. I'm going to share a case study that I did on one of my clients. This was before I had my daughter, and I'll go through it, but So her name is Amanda. That's not her real name, but she gave me permission to share her study. At the time, she was 28, single, heterosexual, Caucasian. She had a history of alcohol abuse and she had struggled with bulimia since she was in her mid teens. She had had 2 DUIs and had had irregular periods since her mid teens due to her eating disorder. She's with a boyfriend. She discovers that she's pregnant at 23.5 weeks. She didn't think she could get pregnant. She had been drinking during this period and running up to 8 miles a day. She had a rocky relationship with her boyfriend, and her boyfriend was afraid of his family's reaction due to his religion. She searched for a doctor who would perform a late-term abortion. She had a lot of issues that she didn't think she could have a child. She was not financially ready. Her relationship was not ready, but she did have good family support. Um, and with all of these struggles, she decided to continue with the pregnancy and pursue adoption. So in that time, she was successful in the remission of her eating disorder symptoms and alcohol symptoms. And she chose a couple who struggled with infertility to be the parents. Amanda gives birth to a healthy baby girl with adoptive parents in the delivery room, but then she felt intense internal struggle, which is uh, not uncommon with a mom giving birth. She ultimately decided to keep the baby, and she felt her role as mom to be more important than her addiction and eating disorder. She still struggled after that. She relapsed at 6 months postpartum, not fully, but she's doing well now, and her baby is thriving. During this time, however, was when I was going through my own fertility issues and losses, and so I had a really hard time. I did a lot of supervision and consultation during this time, um, but I was going through my own losses and was also working with her who got pregnant and didn't really know what to do with it. So it was a complicated situation. It turned out really well, but this is one I like to speak to in terms of eating disorder symptoms concurrent with pregnancy and how the psychological struggles and all of that can really contribute to that. This is what she said. Becoming pregnant and deciding to keep my daughter changed the way I took care of myself since my eating disorder began in 2007. I finally stopped judging myself and beating myself up and really started appreciating how amazing my body was. Despite putting it through so much stress and turmoil, I was growing a little person. I spent many nights in silence, laying on my bed and watching my big pregnant belly move while she kicked me. It's hard to even write this because I cannot imagine life without her now. So, in working with someone who is pregnant with an eating disorder, um, the goal is to immediately reduce these eating disorder behaviors as much as possible. And in her case, these substance use, that's not always a factor. Um, Again, like many women who are pregnant want to cease, as she did, immediately all of these behaviors. It's not always perfect or complete, but we do the best to reduce these behaviors to support the baby growing in the body. Build up the support system. EDF is a great place for people who are struggling with all different issues and related to eating disorders. So if there is if you are pregnant or know someone who's pregnant struggling, they can definitely help as well as family, friends, supportive therapists, supportive dietitian, doctor, etc. And really focus on values. So for Amanda, family, health, honesty were some of her most important values. Um, but what's going to get you through this pregnancy without turning to the eating disorder identity as primary is going to be really important. Reduce shame and highlight strengths of the person, and then a good plan for birth and postpartum, again, with all of those supports in place. In terms of time, I am going to go through, this is another one of my prior clients who had struggled with anorexia and did a lot of fertility treatments, and she had two little girls since then. So, which was really, really awesome to see. Um, and her treatment was really based on highlighting her resiliency, her building her self-compassion, again, values. She had recovered from an eating disorder, but was in recovery when she was struggling with fertility. So, trying to highlight all she had been through and that she got through it and was in a healthy place and just needed some extra support. To tie this all together is the presence of shame, which can affect women like wanting to get pregnant during pregnancy and postpartum. Um, and everybody knows Brene Brown, so she talks about shame in really helpful ways. The intensely painful feeling or experience of believing that we are flawed and therefore unworthy of love and belonging. Something we've experienced, done, or failed to do makes us unworthy of connection. I think shame is much more likely to be the source of destructive, hurtful behavior than the solution or cure. I think the fear of disconnection can make us dangerous. So these are some of the statements that I had felt, and also some of the women that I have worked with have felt around shame and pregnancy or infertility. So I'll just give you a minute to look at these really painful statements, but ones that are felt. What if I don't want to give up my eating disorder during pregnancy? What if I actually don't want this child? I'm broken. So I caused this. So, working with shame and the stigma that can come with weight and eating disorders. So, trying to deconstruct expectations and societal messages about women and becoming a mother. There's so many pressures and messages about that. Trying to identify sources of shame and shame stories and trying to get those out, release them. Stigma about infertility, weight, and eating disorders. There's so much out there. As much as we can educate about that is great. Shame thrives inside. So talking about it again, getting it out, sharing like, oh gosh, I felt that too. I understand why you feel that way. Values is defining values is really important to push through some of these struggles that a woman might experience. And then connection. So connection with other women, our families who've gone through something similar. That was really helpful for me as well. There's my daughter, and this is my book, The Clinical Guide to Fertility, Motherhood, and Eating Disorders, From Shame to Self-Acceptance. Feel free to email me if you have any questions or want any more resources. I've got a lot of research on this topic. So I'm going to leave some time up for questions, and I haven't even looked at all to see if there are any questions. So, yes, if there are any, I'm available.
Awesome. Kate, if you want to go ahead and end the screen share on your
Oh,
end,
there we
let's
go.
pull that up. Beautiful. And I do have some questions here, so I'd like to ask you
Okay.
those. All right, our first one. How can we help increase awareness of eating disorders in the group with OBGYNs? I live in an area where the vast majority of my clients' experiences with OBGYNs are very anti-fat biased, including one OBGYN who told me a client's weight was interfering with her ability to physically have sex. Wow.
Okay. So how can we help educate OBGYNs a little bit more? Oh, it's a great question. I did try to get in with some fertility clinics who were not really interested in me talking to them at the time, but it might be different now. I just think talking about, and this is coming from a therapist, I assume, talking, helping your client learn how to advocate for themselves with the doctor um, about health at every step. And this is terrible that the client should have to advocate for themselves, but it's true, especially in rural or just smaller communities of um, helping say like, well, my health is not based on my weight necessarily, but these are some of the other factors I might be struggling with to get pregnant, that are not health related, and to kind of try to expand the conversation and the dialogue beyond weight. Um, but that's just what I found is many doctors just kind of go like, all right, just focus on your weight first, and then we can talk about these other interventions. And it's kind of backwards. It's just really shame based. So, as much as you can help your client advocate for here's some other things we can look at first, could we talk about that first? That's what I would suggest, but it's a really big problem.
That's something that I've noticed too, just overall with like other individuals outside of even experiencing any kind of infertility or pregnancy issues, is just going to medical providers in general and feeling like that lack of ability to be able to talk about their symptoms in a space of not being judged in it. So that's what I try to always encourage too, is like
Yeah.
it, and always say at the same time, like I don't want to have to ask you to advocate for what you need and to say
Mhm.
like, hey, I don't want to see my weight today, and to be able to let them
Uh-huh.
know. And it also
Mhm.
is like the most helpful tools, like helping prepare clients, community members, and being able to say, like, it's okay to ask for what you need. And like we can develop a plan going into it, bring some educational materials with, even send those to the doctor's office ahead of time to say, would you mind reviewing this? That way we don't have to go
Right.
face to face, because sometimes that can be really intense for the individual. And especially as around with OBGYNs, it's something that's so vulnerable already. Being able to do like a
It's
little
very
bit of,
vulnerable. And
yeah,
again, I think OBs that all doctors don't necessarily know what to ask, and
yeah,
so they need more education as well.
for
Not
sure.
necessarily the patient, but
I know that's always the toughest part for me, is always being like, I wish it could come from somewhere else and we can be our best advocates. So helping empower individuals to be able to do that, usually I found is
hmm
the most supportive.
hmm
When another question that came up, I was thinking about perfectionism in pregnancy and postpartum and then in mothering. So I'm curious if you have any data that you remember or anything from your personal experience too, just around how perfectionism can show up in those spaces.
Oh my gosh, I'll admit I struggled with postpartum anxiety myself, and some of that was the perfectionism, because you get so many different messages from everywhere, like don't do this, do this, don't do this, but then they conflict, and it's like, and you're not sleeping, and you're trying to feed yourself, and it's just like it's impossible. So, um, I just am like, just feed you, feed your child. You'll figure it out. Like it does not need to be perfect at all. And I've had many times just I was crying on my couch like that. It's just reality. And I really tried to rely on my support system as much as possible. And my partner, my husband, he needed a lot of support too. And that's something I didn't talk about too much in this presentation, but I talk about it in my book a little bit more, is like supporting the partner, whether it's same sex or opposite sex, like they need a lot of support too. So EDF and other places like that offer a lot of support. And I went to my local like where I gave birth, and there was support group offered there just for new moms, and that was really helpful for me. So, um, just kind of talking to other moms and being like, "Hey, we're all in this together. Like, what the hell are we doing?" That's just trying to not you can't control pretty much anything at that period of time. So
Yeah.
it's really hard.
Yeah, that's what I right away when I saw like the loss of control, even with like starting in pregnancy too, and just like how many unknowns and in the infertility process too, if that's something that people are battling, is like the loss of control and how much like that can ramp up eating disorder symptoms and behaviors too.
Yes.
So how much
Hmm.
of, I think like tug of war came up, that was on a couple slides that I really connected with, of like, oh yeah, I bet that's so conflicting for like wanting to be able to like conceive and then also struggling with like the eating disorder thoughts that are coming in too, and just that back and forth all the time. And then same with the
Yeah, wanting to find a
perfectionism.
sense of control when there is, especially when your body, if you are pregnant, but like
Yeah.
when your body is changing pretty,
Yeah.
it's the most rapid time your body will ever change in your entire life. So it's a lot. It's really exciting, but
Yeah.
it's also a lot. There's the battling identities that
For
can come
sure.
up there.
Yeah.
Mhm.
It sounds like just talking through the perfectionism piece and recognizing like this is not going to be a thing that I'm going to be able to do is reach perfectionism in this. So really getting like right sized on like the expectations for yourself sounds like it was really helpful in recognizing like the support that's needed for both you and your husband in that situation for being able to say like, yeah, we cannot do this alone and being able to like reach outside of your family system and be like, okay,
Oh
what else
yeah,
can we
you
bring
cannot do it
in?
alone at all. And this, I feel like the Western culture is like, here you
Mhm.
go, now good luck, and it's just really traumatizing for new parents. So recognizing that there's a lot of need and support out there to be together during that time of pregnancy and postpartum.
Yes, absolutely. I had another question that was percolating in my brain, but now I've lost it. But those are the questions that we have so far. But I'm wondering if there's anything else, Kate, that you just wanted to touch on or any last things that you were thinking of.
Just reiterating that you're not alone, whether you're struggling with an eating disorder, period, whether you're struggling with an eating disorder, wanting to think about starting a family. I'll say when I was going through my eating disorder and I was really young, I didn't think about wanting to have a family, and that's pretty common.
Mhm.
And that's again contributed to the shame that I experienced later when I did, and I didn't, I had some losses, and I was like, oh my gosh, me when I was 15, did I ruin my body? And as I said too, like most likely no, if you are, really working on recovery and are recovering your health, that is not going to be a factor in your fertility unless there's other non-ED related issues that can factor in. But um, that it's something that everybody, we're all kind of figuring out together, and you're not alone, and there's a lot of support out there. And since I've done this journey and worked on this book, there's been just plethora of people coming out of the woodwork like, yes, I get it. And actually in my book I interviewed like 35 people who were like, yes. And so that was so exciting for me. I'm like, we are not alone. Like, you are not alone, whether you're on this journey, have been on this journey, want to go on this journey. So let's get the shame and the stigma out of the way with that.
Absolutely. I'm right on board with that. That's why one of my really good friends works in she's an acupuncturist and she's learned so much more about infertility and how like eating disorders can play a role in it and just fertility struggles. And that's been something that she's been implementing in her practice too, is like just reducing the shame right away and being able to say like, hey, you're welcome to talk about that if like fueling and nutrition is something that's been a battle in the past, like let's bring that present so we can reduce that shame and stigma to be able to help work together more. Because I think it is something that like the shame keeps it so like so pressed down and being able to release
Yeah, don't want
that
to
and
talk
just be
about
able
it,
to
of
like,
course. Yeah.
yeah, be able to
Like bring it up
acknowledge
to your
and
doctor. Like,
mhm,
yeah.
anyone
Acupuncture was really
supporting.
helpful for me too in my fertility journey, I'll have to say.
That was something that I've learned so much about it and like the impact that it can have and knowing that it can be available and helpful for some people and also maybe not available due to, different barriers of entry to it, but something that I learned a lot about and just additional support, if anything, a way to keep talking about it and get more awareness around it, which I know the advocacy piece and talking about it can be really challenging. And I think it's one of the most beneficial things to continue to just like yeah, the more we release it, the less strength and power the stigma and the shame has on our own journeys. So thank you so, so much, Kate. This is one of the topics that I've been wondering a lot about and hopeful that folks in our community will be able to release some of that stigma and shame around it and be able to recognize like this isn't my fault and it's not something that I've caused. And there's ways that I can receive support and continue on that journey and not be alone in it. So thank you so, so
Of
much. And
course, I'm
thank
always
you.
here to talk. So thanks for having me.
Of course. And thank you everyone for joining this evening. If any questions come up, we'll have Kate's email address in the notes on the YouTube recording, and she's available if anyone wants to reach out and be connected. And thank you everyone. Have a beautiful rest of your evening.
Thank you. You too.
Thank you. Bye everyone.